We heard about the surgery. Now, so what do we do after surgery? After surgery, we have to do something because, as you're going to see, how do I pass the next? Oh, there. These are some numbers that, when you look at them, they're not very promising. And if you don't do anything about patients with pancreatic cancer that have been resected, even though the resection has been complete and you took everything out and there's margins negative and there's nothing left behind, 5-year survival, 3%. And as you can see there, only 20% of the patients can get resected. And obviously, if the tumor is less than 3 centimeters, maybe those are negative, margins are negative, the survival could stretch to 30–40%, but that depends on the stage. And usually the pancreatic cancers are bigger and they're diagnosed late, and it's a disease that, unless you do something about it, the prognosis is still bad, even after surgery. Untreated patients, that means that patients who did not have surgery, 5–7 months, with local advanced disease, and metastatic disease 2–3 months. So it's a rapidly progressing, aggressive type of cancer. So what we do is called adjuvant treatment. Adjuvant treatment means we do something after surgery, that's a term of adjuvant, to try to improve the survival. And the concept is if you give radiation or chemotherapy or something like that, you are killing the micrometastases, the disease, the small metastatic lesions that the surgeon cannot see. The surgeon goes in, takes the bulk of the disease, but the cancer may be spread already to different organs locally. So by doing this, you kill the micrometastases, the patients live longer. To a certain extent. So adjuvant therapy, treatment after definitive therapy, which is surgery, that's considered definitive therapy. There's no clear consensus to what kind of adjuvant therapy you use. There's a different philosophy between Europe and North America, and we're going to clarify a little bit better now what it is. So this is fairly recent, 2001, so 15 years ago. There were only three randomized trials. Randomized means that you do a study that has one arm and another arm, and you can decide which group goes into what arm, which patient goes into what arm, and then you compare both arms and see which one is better. That's called randomization. You basically flip a coin and say, okay, you're getting this or you're getting that. And it's very difficult to do in pancreatic cancer because it's an aggressive disease, it goes fast, it's hard to accrue. So these are the trials that were up to 2001, very small amount of patients. You can see 218. Well, here it's more, but this trial actually accrued a lot of other people, not really all pancreatic. And this is a trial that actually led to the fact that adjuvant chemoradiation, so this is the abbreviation, chemoradiation therapy, was better than doing just surgery alone. This is a p-value. This is a statistical number that says that if you're less than 0.05, it's statistically sound and it's probably real. Okay, so that's the number. So not a lot of information until fairly recently. So then in 2006 and 2007, two major trials came out. The RTOG 9704 and the Congo trial, which is a German trial. And just to go fast through this trial, what it did, what the idea of the trial was, enroll a lot of patients. All of them, not all of them, but most of the patients had pancreatic tumors, as Dr. Pireki said. Those are the most common ones. And they were randomized to get either one chemo type, which is 5-FU, versus another chemo type, which is gemcitabine, followed by both arms getting chemoradiation to see which one is better. This is the schema of it. Pretty simple. You get this chemo or this chemo, then you get chemo. Obviously, you had surgery before. Cancer was removed. Chemo, different type. Chemoradiation, everybody gets the same, and then chemo again. And the numbers show that people that got the chemoradiation and the chemotherapy with the drug called gemcitabine, which was the arm B, did actually better than the other arm. So since then, in 2006, 10 years ago, that's the standard treatment that we use here in the United States. So far, still. Gemcitabine followed by chemoradiation followed by gemcitabine. Now, this is the Congo trial. This is a European approach, and still is a debate about what to do if radiation therapy plays a role in this cancer, and Dr. Karenpour will talk about that. But this is the German trial from 2007 that actually they didn't randomize patients to radiation. They just did Observation versus chemotherapy. The same type of patient, the 368 patients, resected, and the chemotherapy were 6 cycles of this drug called gemcitabine every 4 weeks for 6 cycles. And again, this is a schema, 6 months versus observation, and follow-up every 8 weeks. Pretty simple design. And this is a survival curve. So you can see that observation, obviously, worse than gemcitabine. And this is the overall survival. The P here was not less than 0.5. However, there was an update to the trial in 2008 that showed that the 3-year survival was much better than gemcitabine as compared to observation, which is a proof of concept, meaning that you have to do something after surgery, because if you do, people do better, no matter what you do. In this case, only chemo. In the other case, in the other trial that we showed, it was chemoradiation. But obviously, both things point towards an improvement in survival if you do something after surgery, and the P here was significant. This just to show it. This is what the Japanese are doing, and this drug is not available in the United States for many reasons. It's a combination of 5 few and different things. And apparently the Asians have a better response to the drug than we do. It's been tried in different cancers, and it hasn't been approved in the United States for that reason. But anyway, just to show the concept, this is called the JASPAC-01 trial, phase 3 trial with adjuvant gemcitabine versus another drug. So we know gemcitabine is better than observation, based on the German trial. Now they tried, well, what if we do gemcitabine versus another drug without radiation and see what happens? And the Japanese, this is the study design, essentially the same thing, resected, randomized, then the stratified patients by institution, so everything looks like it's clean cut. This is the way we conduct trials, is to know that we're not introducing more biases than we need to. There's always a bias, but in this case, when you randomize and you stratify and you do things this way, everything is by chance, so the biases are much less. So you put gemcitabine on one side, the same regimen that has been used in the German trial, versus S1, which is this new drug, or all new drug, because they've been using the drug for 20 years, but we don't have it here. And they saw that the S1 is better for them. Now, is that true here? Probably not. We've done other things in other cancers, and this drug in the Western population doesn't work that well for several reasons. But anyway, just to prove the concept that, you know, here you have different curves, the S1 was better, and obviously if we have a surgery alone curve, it would have been like around like this, all right, like here, because we know the surgery alone doesn't cut it, doesn't do it. Now, what is this CONCO5? Obviously, the other one was CONCO 001. This is CONCO 005. So it's the same people trying to prove that what happens, or trying to figure out what happens if we add another drug, cortelatinib, to this gemcitabine that already they saw it worked. But now what happened if we add another drug? Now what happened with this drug? This drug was used in the metastatic setting. Not in the setting after surgery, but they're using it when patients have metastases. And there was an improvement in survival as compared to Gemcer alone, but it was very little. It was 2 weeks improvement. So the drug was approved for that purpose, for treatment of metastatic colon cancer, with an approval of with an improvement in survival of 2 weeks. Nobody uses it because it's so expensive and has side effects and all that, so nobody's going to spend money on 2 weeks survival. However, they conducted this trial in the adjuvant setting, saying, well, what happens if we try in this setting after everything was resected, and maybe we get a better result. So they went in and they designed this trial, and it's the same concept. It's important for you to understand the concept of what randomization is, because we talk to patients all the time. We're going to randomize it. We're going to do this. It's based on this trial. We have a trial that randomizes. So this is the concept, so you understand what it is. Oh, sorry. So here, gemcitabine alone, the same regimen, the same way, the same type of patient, again, stratified and done correctly, with the addition of erlotinib daily, which is a pill. And here, the survival is the same. And now, don't get fooled by this little thing here, but if you look at the numbers, median survival exactly the same, events a little bit more in the gemcitabine, but then the P is not significant, as you can see here. So it didn't work. And so the addition of another drug to this backbone, it didn't do what they wanted the drug to do. I'm running out of time, so I'm sorry, that was the C-fish survival, this is the overall survival. And it's the same thing. It's basically, there's no separation of the curves. No, we call separation of the curves, meaning that the curves are basically running equal all the way down. So just by looking at the curves, you can tell there's no signal. Nothing is happening. So what is the conclusion? Well, easy to see. It didn't work. All this words to say, it didn't happen. Now, what is the future? And I'm going to cut it here. I have more slides that are interesting in the neoadjuvant setting. What is neoadjuvant? Neoadjuvant is, what if we do chemo and radiation or something like that before we do surgery? That is, try to shrink the tumor before and see if the surgeon can do a better job, especially in borderline resectable. Cancers are not all there, but if you shrink it a little bit more, maybe you can take it out. But I don't have time to talk about that. I'm sorry. So we're going to talk about this. So this is what is happening now for in the adjuvant setting. And so what this combination, this weird word here, FOLFIRINOX, is 3 drugs. We use FOLFOX for colon cancer, which is 2 drugs. This is FOLFIRINOX. So you try to put the kitchen sink all together and see if that works. This worked for metastatic pancreatic cancer. It showed improvement in survival as compared to gemcitabine alone. So the guys are saying, well, what if we use this in the adjuvant setting after surgery instead of gemcitabine alone? And maybe we get a better result, which is logical. I would do the same thing. The same thing they did with the erlotinib that didn't work. They try to do this here, but this is a different thing because this really has a big signal in metastatic disease. It's much better. And so they're randomizing this versus gemcitabine alone. And this is another trial, APAC, that I tried to get it open here in this institution, finding we couldn't do it, which is another type of regimen, which is gemcitabine nab-paclitaxel. This is Taxol, that also works in the metastatic setting, and they're trying to push it into the adjuvant setting to see if we can improve survival that way. So these 2 trials are big, and they're going to come out probably in a year or a year and a half. So we'll have some results on the addition of these drugs in the adjuvant setting. Vaccinations, immunotherapy is going on, and there's some signals on that. And that's it, because this is molecular. I'm not going to get into that. And I'm going to leave you with a new adjuvant that I can't talk about. How many? That's it. Are we done? Are we done? Okay.